So today is the last lecture. We will be discussing the neck structures, the thyroid gland, and the parathyroid glands. So let's start with the neck anatomy. The anatomy of the neck can be divided in relation to the hyoid bone into suprahyoid neck and infrahyoid neck. So from the level of the base of skull to the hyoid bone is suprahyoid, and inferior to the hyoid bone to the clavicles is the infrahyoid neck. This is an illustration from Gray's anatomy. So this is the hyoid bone. Superior to the hyoid bone is suprahyoid, and inferior to the hyoid bone is infrahyoid. Although there are some structures that does not respect this boundary, they extend from supra to infrahyoid. We will see these structures shortly. There is another type of subdivisions of the neck that's into anterior triangle and posterior triangle. This is in relation to the midline, to the sternocleidomastoid, and to the trapezius muscle. We will see these subdivisions shortly. To divide or to compartmentalize the neck, there are some fasciae that separates the structures of the neck. We will discuss these fasciae and the spaces that they enclose, so we know each compartment has what kind of structures. So when there is a pathology, we know what kind of differentials that we should have. So the investing fascia is the fascia that completely surrounds the neck, and it splits to include the sternocleidomastoid and trapezius muscles. We will see this fascia shortly. There is also another one which is more superficial that includes the platysma muscles as well. Then the deep cervical fascia has several layers and form boundaries for the deep spaces of the neck. The first one is the pretracheal fascia. This is anterior to the trachea, and it encloses what is called the visceral space. In the visceral space, we will have the trachea, the thyroid glands, the esophagus, and the recurrent laryngeal nerve. Yeah. Then the prevertebral fascia, that is anterior to the vertebral body. It includes the structures that are surrounding the vertebral body. So the paraspinous muscles, the vertebral bodies, the spinal cord, the vertebral arteries, and so on. Then the carotid sheath, from the name that it is having the carotid, but we know within this space there is also other important structures, including the internal jugular vein and vagus nerve. So this is an illustration for these fasciae of the neck. The fascia highlighted in blue is the investing fascia that we said that is surrounding the whole neck, and it splits anteriorly to include the sternocleidomastoid, actually on both sides, then posteriorly to enclose the trapezius muscles. So this is the investing fascia. Then the fascia that is surrounding the visceral space is the pretracheal fascia. In this space we have the trachea, the thyroid glands, the esophagus, and so on. And we will have some branches of blood vessels and nerves. Then this fascia that is anterior to the vertebral body and including the paraspinous structures is the pretracheal fascia. This is the carotid sheath or carotid fascia that includes the carotid space, including the common carotid, the internal jugular, and the vagus nerve. This is a sagittal view of these boundaries. So this is the prevertebral layer. This is the pretracheal layer, posterior portion. This is the anterior portion, and the one that's highlighted in blue, most anteriorly and most posteriorly, is the investing layer. Then this fasciae divides the neck into several compartments or several spaces. We need to know these spaces, as I said, to know the differentials that we should have when we have a pathology. The other thing that the pathology usually respects these boundaries. So if there is an infection or sometimes even tumor, it extends first within this space before it invades the surrounding structures. So we need to know these boundaries and these spaces. In the suprahyoid neck, we have the parapharyngeal space. This is central in the deep fascia. We will know this shortly. The parotid space, which contains the internal carotid, the common carotid, and with internal and external, of course, and the internal jugular vein and the vagus nerve. The pharyngeal mucosal space, this is around the pharynx and its mucosa. Masticator space that has the mastication muscles, the masseter, temporalis, medial and lateral pterygoids, and the mandible. The buccal space and the danger space. And this space is named danger space because it's the space that is connecting the neck to the mediastinum. Usually, it's indistinguishable from retropharyngeal space unless there is a fluid or pus collected within this space. Then this pus will extend all the way down to the mediastinum and cause mediastinitis. That's why it's called the danger space. In the infrahyoid neck, we have the anterior cervical space, the posterior cervical space, and the visceral space that we have talked about. Some structures does not respect this kind of subdivisions, so they have supra and infrahyoid extensions. So the carotid space is considered supra and infra. It includes the carotid arteries, the internal jugular vein, and cranial nerve number 10, which is the biggest nerve. The retropharyngeal space and danger space, and prevertebral space, which includes the vertebrae, the spinal cord, the paraspinous muscles, and the vertebral arteries passing through the transverse foramen of the transverse processes of the cervical vertebrae. So let's have this series here, which annotate these spaces. So this one that is highlighted in blue is the masticator space, which include the masseter, the mandible, the medial and lateral pterygoid, and the temporalis. We go down and we see these structures. So this is a part of the buccal space that surrounds the maxillary sinus and the oral cavity inferiorly. Then we have the parapharyngeal space, this space here. This is what is considered to be a central in the deep fascia because it has contribution from all of these spaces. So it has a relation to the masticator, to the carotid, to the prevertebral, and so on. And this space does not include any important structures. What it includes is just fat. But it's important because when there is a pathology for any of these spaces, they will extend to this space. So when there is obliteration of this space, we need to know where is the pathology is coming from. Then we have the retropharyngeal space and danger space, which are indistinguishable from each other normally. The prevertebral and perivertebral space, the carotid space, the pharyngeal mucosal space, which is this one, surrounding the pharynx and its mucosa. Here we see we have the sublingual space, inferior to the tongue. And this is the submandibular space, which will contain the submandibular gate. When we go down here, we start to see the visceral space. This is the visceral space, which includes the trachea, thyroid glands on either side, the esophagus, the recurrent laryngeal nerve, and some branches of blood vessels and nerves. As you see here, the retropharyngeal and danger space are extended into the mediastinum. So now we're almost in the chest, in the mediastinum. But this space is still extended to this position. That's why it's dangerous. When there is infection, there will be an extension to the mediastinum. The other classification system of the spaces of the neck is to be divided into anterior and posterior triangles. The anterior triangle of the neck is outlined by the anterior border of the sternocleidomastoid muscle on either sides, the inferior border of the mandible superiorly, and the midline of the neck medially. Let's have a look to this triangle. This triangle highlighted in light blue here is the anterior triangle. As we see, the boundaries are the inferior border of the mandible, the anterior midline, and the anterior border of sternocleidomastoid muscles. But then this triangle is also divided into several small triangles, including the submandibular, the submental, muscular, and carotid triangle, but this is not our focus. On the imaging, we will usually focus on the spaces that we have talked about that respects the boundaries made by the fasciae of the neck. These subdivisions is to make it easy to know what is the structures and where are they found. So the muscles in the anterior triangle can be divided again into suprahyoid and infrahyoid. The suprahyoid muscles include the stylohyoid, the digastric, the mylohyoid, and geniohyoid. We talked previously about the mylohyoid and geniohyoid when we talked about the floor of mouth. So we are left with the stylohyoid and digastric muscle. This is an illustration of the suprahyoid muscles. So this is the geniohyoid, and this is the mylohyoid, which forms, it's cut here, which forms the floor of the mouth. Then we have the digastric with two bellies, the anterior belly and posterior belly of digastric muscle. Then this is the stylohyoid, which is extending from the styloid process to the body of mandible. So this table is to show the origins, the insertions, the innervation, and the action of these muscles. The infrahyoid muscles include the omohyoid, the sternohyoid, the thyrohyoid, and the sternothyroid. Let's have a look to them on this illustration. The omohyoid is this one, which has two bellies, superior belly and inferior belly. The omohyoid is originating from the upper border of the scapula, then it's inserted on the lower border of the hyoid bone. The other muscles in the infrahyoid area is the thyrohyoid, which is extended from the lower border of the hyoid bone to the oblique line of thyroid cartilage. The sternothyroid, which is extending from the sternum, particularly the posterior surface and the manubrium of sternum, to the oblique line of thyroid cartilage. Then we have the sternohyoid, which is extending from the posterior surface of the sternum to the lower border of the hyoid bone. Then there are several nerves that are passing through the anterior angle of the neck, including branches from cranial nerves and branches from peripheral nerves. The cranial nerves that are passing through the anterior angle of the neck include branches from vagal nerves, the glossopharyngeal, vagus, accessory, and hypoglossal. And the peripheral nerves include the transverse cervical nerve from the cervical plexus and the upper and lower roots of ansa cervicalis. So this is the course of accessory nerve, and because accessory nerve has a portion in the anterior triangle and a portion in the posterior triangle, we will talk about it again when we talk about the posterior triangle. It passes deep or through the sternocleidomastoid and it innervates it. Then it passes superiorly here, superficially. So this location is the most part of the accessory nerve that is susceptible to injury because it's superficial. Then it goes again deeper to the trapezius muscle and innervates the trapezius muscle. This is the course of hypoglossal nerve. and this is the course of the vagus nerve, which is running within the carotid space along with the internal carotid artery, and then the common carotid artery down, and with the internal jugular vein. This is the course of glossopharyngeal nerve and its branches. And this is a transverse cervical nerve, which is branching from the cervical plexus. The facial nerve, after it emerged from the stylomastoid foramen, we knew this when we talked about the ear and temporal bone. Then it gives off several branches. The branches that are associated with the anterior triangle are the branches that innervate the posterior belly of the gastric and the stylohyoid muscle. Then the ansa cervicalis. The ansa cervicalis is a loop of nerve fibers from cervical nerve C1 to C3. They innervate the muscles in the anterior triangle. So it begins as branches from C1, and then it joins the hypoglossal nerve soon after it leaves the skull. This is the ansa cervicalis loop. As we see, it's branching from C1, C2, and C3. And the branch that is coming from C1 is then joining the hypoglossal nerve after it's coming out from the skull base. We move on to talk about the posterior triangle of the neck and its structures. The posterior triangle is on the lateral aspect of the neck, and it is in direct continuation with the upper limb. The borders of the posterior triangle include anteriorly the posterior edge of sternocleidomastoid muscle, posteriorly the anterior edge of trapezius, and the base is the middle one-third of clavicle, and the apex of this angle is the occipital bone just posterior to the mastoid process. So we see this illustration. This is the posterior triangle of the neck. It's on the lateral side of the neck. So it's bordered anteriorly by the posterior border of the sternocleidomastoid muscle, and posteriorly by the anterior border of the trapezius. The base is the middle one-third of clavicle, and the apex here is the occipitus just posterior to the mastoid process of temporal bone. The floor of the posterior triangle include all of these muscles: splenius capitis, the levator scapulae, and 3 scalene muscles on either side. They are the anterior, middle, and posterior scalene muscles, and the omohyoid muscle, particularly the inferior belly. So these are the muscles that are found within the posterior triangle of the neck: the splenius capitis, the levator scapulae, the 3 scalene muscles, the anterior, middle, and posterior, and the inferior belly of omohyoid muscle, because the superior belly is within the anterior triangle. So let's talk about the large 2 muscles of the neck, which are the sternocleidomastoid and the trapezius muscle. And these are the ones that make these boundaries between anterior and posterior triangles. The sternocleidomastoid, as the name may explain, it's extending from the sternum, the clavicle, and then to the mastoid process, right? So it has 2 heads, the sternal head and clavicular head. Yeah. And then it inserts, it origin from the mastoid process of cranium. Then it inserts on these 2 structures with these 2 heads. The trapezius muscle is a large, huge muscle which has a very long origin. So it's originating from the superior nuchal line, the external occipital protuberance, the occipital bone, the ligamentum nuchae, the spinous processes of C7 to T12. So that much long. Let's come back to this. Yeah, this long origin. So all of this is the origin of trapezius. And then it's inserted on the lateral third of clavicle, the acromion and spine of the scapula. Both of these muscles are innervated by the accessory nerve, as we saw previously, and we will illustrate again. So when there is an injury to this nerve, it will affect the function of these muscles, which is elevation and depression of the shoulder and rotation of the head. The other muscles with their origins and insertions are illustrated in this table. So the splenius capitis originate from the lower half of ligamentum nuchae and spinous process of C7 to T4. Then it's inserted on the mastoid process. The anterior, middle, and posterior scalene muscles are originating from the transverse processes of cervical vertebrae. So the anterior is originating from C3 to C6. Yeah. And then the middle is originating from C2 to C7. Yeah. So this one has a larger origin, wider origin. Both of them are inserted on the upper surface of rib 1. Let's go back to our image. Yeah, this image. So these are the anterior and middle scalene. Both of them are inserted on the upper surface of the first rib. And then the posterior is originating from C4 to C6, and then inserted on the upper surface of rib 2. So this is the second rib. This is the insertion of posterior scalene muscle. Levator scapulae originate from the transverse process of C1 to C4 and then insert in the upper part of the medial border of the scapula. So here we see a portion of the levator scapulae muscle. These muscles actually are very complicated. So what you need to see on the images, if there is a pathology, then you need to follow the course of the muscle so you know which particular muscle is this. Then finally of the muscles is the platysma muscle. It's this thin, flat, sheet-like but large, covering a very wide area. It's originating from the skin of the lower face, the mandible, and the angle of the mouth, and extends all the way, covering all the structures, almost all the structures of the neck, and overlies on the sternocleidomastoid muscle to the upper skin of the chest below the clavicle. You will see this on the images shortly. The other contents of the posterior triangles, including some blood vessels that we already talked about, the external jugular vein, subclavian artery and its branches, the transverse cervical and suprascapular arteries, and the subclavian vein. So this is an illustration of the external jugular vein and the transverse cervical vein within the base of the posterior triangle. This is the internal jugular vein, the thyrocervical trunk and its branches, the brachial plexus, and some other nerves, including the vagus and the phrenic nerves. The accessory nerve, as we said previously, it passes either deep or through and innervates the sternocleidomastoid, and then it descends superficially, and then again it goes deeper to the trapezius muscle. So because of this superficial location, it's susceptible to injury and need to be evaluated. This is the course of the accessory nerve within the posterior triangle of the neck. So let's move on to have these images to review what we have learned about the neck. Here we have the mentalis muscles. These are the muscles on the chin. This is the inferior dental arch. This is the floor of the mouth, the genioglossus muscles, and the lingual septum on the midline. This is the masseter muscle, the styloglossus, which is one of the external muscles of the tongue, the medial pterygoid muscle, and this is the oropharynx. This is the hypopharynx. This thin hypointense line is the platysma muscle because it's very thin, sheet-like muscle, and this is a cross-section, an axial image. So what we see is this line of this muscle. Here we have the thyroid and sternothyroid muscles and sternohyoid. So the infrahyoid muscles are contained within this area. This is the piriform sinus, the common carotid artery, and this is the internal jugular vein. Internal carotid, common carotid and internal jugular vein. More lower down, we start to see the thyroid cartilage, the glottis, which is the opening of the air and voice, the arytenoid muscle, platysma, and this is the anterior jugular vein. Here. This is the prevertebral fascia. So what it includes inside all is the pre and perivertebral space. This is the pretracheal fascia, including the visceral space, which includes the thyroid glands, the trachea, the esophagus, and the vagus nerve, but it's a very small structure to be seen on the images. These are the scalene muscles. From anterior to posterior, they are the anterior, middle, and posterior scalene muscles. And here we see the paraspinal muscles. This is a coronal T1 MR image. So here we see the lateral pterygoid muscle. See the nasopharynx, the uvula, soft palate, the medial pterygoid muscle. This is the common carotid artery. This is the epiglottis, the sternocleidomastoid muscle, this large muscle on either sides, and the thyroid glands, which are seen iso-intense to the other soft tissue structures. So our next part, and the last part actually, is the thyroid and parathyroid glands. We know that thyroid gland is one of the most endocrine glands for the life of human body. So it's found in the neck and completely enveloped by the middle layer, which is the pretrachea, within the visceral space. It extends from C5 to T1 and lies anterior to the thyroid and cricoid cartilages of the larynx and the first three tracheal rings. It has a butterfly or H-shaped structure, and it is composed of two loops with an isthmus which connects the two loops, and it measures approximately about 4 centimeters for each loop. This is an illustration of the structure of the thyroid gland and its relations. So this is the thyroid gland, left lobe, right lobe, isthmus. As we see, it overlies the thyroid cartilage, the cricoid cartilage, and the first three rings of the trachea. And this is a cross-section illustration. This is what we call the visceral space, and this is the thyroid gland. This is the vagus. This is the right recurrent laryngeal nerve, and this is the esophagus. This is the trachea. This is a transverse ultrasound. So what we see here at the center is the trachea, and this echogenic structure on either sides is the two lobes of thyroid gland and the isthmus at the midline. Here we have the common carotid artery and the internal jugular veins on the lateral side. When we have another larger image, we may see these two structures together. Yeah, this one. This is the magnified image. So this round one, small one, is the common carotid. Then more laterally to it and anterior, oval shape, sometimes slightly irregular because it's compressible, is the internal jugular vein. This is an isotope study. It shows the uptake of the isotope by the normal thyroid glands. The blood supply to the thyroid, we already talked about some of them when we talked about the blood supply to the face and neck. So it has the superior thyroid and inferior thyroid arteries. The superior thyroid branch from external carotid artery, and inferior thyroid originates from the thyrocervical trunk, which is originating from the subclavian. Yes. Sometimes the inferior thyroid artery arises from the subclavian artery directly. So this is called an accessory inferior thyroid artery. Then the venous drainage is via the superior, middle, and inferior thyroid veins. The superior and middle drain into the internal jugular vein, and the inferior thyroid drains into the brachiocephalic vein. This is an illustration of the vasculature of the thyroid gland. So let's review what we have learned about its vasculature. This is the common carotid artery. It bifurcates here to form the external and internal. Then, after the bifurcation, the first branch is the superior thyroid artery. If you remember the mnemonics, some anatomists like freaking out for medical students. So the first branch is the superior thyroid. Yeah. It's this one. Then the inferior thyroid is this one here. Let's see this illustration. So posteriorly it's more clear. This is the inferior thyroid, which is originating from the thyrocervical, which is coming from the subclavian. Then the venous drainage is via the superior and middle thyroid veins, which are draining into the internal jugular, and the inferior thyroid vein, which is draining into the brachiocephalic vein. Then the lymphatic drainage is multidirectional, but the initial drainage is to the parathyroid lymph nodes, then into the prelaryngeal and pretracheal and paratracheal nodes. So mainly the level 6 lymph nodes. If you remember the classification of the levels of neck lymph nodes, level 6 is this central compartment. It's the compartment that contains the thyroid gland. So the initial drainage of the thyroid gland will be to this level. Before we see this image, let me ask a question. What do you suspect the normal density and normal signal intensity of the thyroid gland on CT and MRI images?
Hospital should be hyperdense because of content.
Hyperdense, right? That's true. We know that iodine contrast is one of the contrasts. It's actually the most common used contrast for the CT images. So, because thyroid gland, it contains a minimal amount of iodine, it's hyperdense. It's slightly hyperdense on CT images. What about MRI? It's iso, because iodine is working on CT, but on MRI it has no role. Yeah. So on MR images, it's iso. What we have here is axial contrast enhanced CT image of the thyroid gland. So we see the carotid arteries filled with contrast agents, right? And then we see the thyroid glands which are enhancing. Why they are enhancing? Because they are hypervascular, right? Because of the hypervascularity, as it is with most of the endocrine glands. Then this is the jugular vein. This is a sagittal image, contrast enhanced. So this is the thyroid gland, superior pole and inferior pole, carotid artery posterior. On MRI, this is T1 without contrast, so we cannot differentiate it from the surrounding muscles, right? Yeah. But post-contrast here, we see the thyroid gland enhancing, so you can see clearly the left lobe, the isthmus, and right lobe, then the carotid arteries and jugular veins. This is a coronal T1 MR image without contrast. So this structure here is a thyroid. As you see, it's iso-attached to the surrounding soft tissue. There are some variant anatomy of the thyroid gland which we should be aware about, and the surgeons who perform any interventions to the thyroid should be aware of. This variant anatomy include lobar hemiagenesis, which is partial or complete agenesis of one of the thyroid lobes. Then pyramidal lobe, this is considered the third lobe, which is projecting from the isthmus. Thyroglossal duct cyst, this is a midline cyst, and this is the most common neck mass in young population. It results from obliteration of the thyroglossal duct. So it can occur at any position of the long course of the thyroglossal duct. The ectopic thyroid tissue, when the thyroid gland did not migrate to its normal position, so it can be found elsewhere. The most common location is within the base of the tongue. Therefore, it's called the lingual thyroid. Zakar Kandel's tubercle, we'll talk about this variation shortly. Then, in some population, the thyroid gland is supplied by a thyroidea ima artery, which is the artery originating proximal to the inferior thyroid artery. So, what do you see in this image? This is transverse ultrasound, this is color Doppler, and this is nuclear medicine, nuclear images. Do you see any abnormality?
I think there's a hyper.
It should be one of the variations that we have learned, nothing else. Okay, this is a coronal image. So this is a sublingual gland, and this is the left lobe. What is the right lobe? It's not there, yeah. It's not there. So this is a case of agenesis of right thyroid lobe. What about this one? Here we'll have a series of images. So have a look to this. Do you see any abnormality? You can see again. This is the left lobe, right? This is the right lobe. This is the isthmus, but it's slightly thick, right?
Yeah.
Okay, let's continue.
Are you able to do?
Yeah.
Yes, there's a projection.
There is a projection from the isthmus, right? So what is this?
That's
This one, right?
yeah.
So this is the third. This is the third lobe. This is called pyramidal third lobe, pyramidal thyroid lobe. So it's projecting from the isthmus. This variation is found in 10 to 30% of population. So it's common. What about this one? This is a female, 40 years old, presented with dysphagia. Please have a look to the thyroid gland. This is contrast enhanced CT.
It's on the base of the tongue.
Yeah. Did we find any?
No thyroid tissue.
No thyroid tissue, right?
It's supposed to be
Yeah.
higher up.
Yeah. This is the trachea, right?
Yes.
This is the trachea here. And then we move up here, we start to see a thyroid cartilage. Nothing. It should be lower, and there is a small portion of thyroid cartilage. It's overlying the thyroid cartilage, the cricoid, and the first part of the trachea. But none of them contains any structure of thyroid. But when we move up, we found this mass. This mass, which is enhancing at the base of the tongue. So this is the thyroid gland. This is an ectopic thyroid gland. So this is a case of ectopic lingual thyroid, which is the most common location of ectopic thyroid. We have to talk about this variation, which is the Zakar-Kandel's tubercle, because if the surgeon is doing any thyroidectomy or any other interventions of the thyroid, they should be aware of this variation if it existed, because of its relation to the recurrent laryngeal nerve, and superior parathyroid gland. So they don't cause any injury to these important structures. So this variation is a projection of normal thyroid tissue from the posterior aspect of the lateral lobes of the thyroid gland, as we see in this illustration. This projection is what is called the Zucker-Kandel story. So it can be mistaken for a thyroid nodule or mass or lymph node. But how we will differentiate it from these pathologies?
Same characteristics.
Yeah, it has the same density on the contrast images. It has the same enhancement pattern on post-contrast images. It has the same hyperdensity on CT. It has the same iso-intensity on MRI. So when we say it's similar to thyroid, we know that this is a normal thyroid tissue, but it is this variation. Another point that this variation is also susceptible or can have some diseases similar to the normal thyroid tissue. So cancers and goiter. I saw a case of retrosternal thyroid goiter. It was at a projection which is projecting from the thyroid gland. So it was this variation. Finally, we talk about the parathyroid glands. The parathyroid glands are normally two pairs of parathyroid glands, inferior, and two pairs superior. So they are found at the upper pole and the lower pole of each thyroid gland. But they can be numerous, up to 12 in number. They are oval in shape or bean shaped, usually measure 6 by 4 by 2 millimeter and weight 40 to 60 milligram. Normally we cannot see this structure because of this small size, but ultrasound and nuclear medicine are the most important used imaging techniques for evaluation of parathyroid glands. That's because of on ultrasound, it's hypoechoic compared to the overlying echogenic thyroid gland. We will have an image shortly. The parathyroid glands play an important role in calcium and bone metabolism, and the 4 parathyroid glands are situated at the poles of the thyroid, as we said. The upper parathyroids are posterior to the upper pole, and the lower parathyroids are lateral and inferior to the lower poles, but can be ectopic in 35% of the population. They are isoechoic to thyroid parenchyma. It should be isodense to the thyroid parenchyma on CT, but on MR, on ultrasound, they are slightly hypoechoic here. So these are the parathyroid glands. This is the left superior parathyroid gland, right superior, left inferior, and right inferior parathyroid glands. So this is an image of the thyroid and parathyroid glands. As we see, the thyroid gland is echogenic, but the parathyroid gland, which is here, is slightly hypoechoic compared to the thyroid gland. That's how we differentiate. Parathyroid glands can also have some variations. The first one is the supernumerary glands. So they can be more than 4. And the incidence of this variation is about 15%. They can be fewer than 4 in about less than 3% of population. And the ectopic parathyroid glands can also occur. It's most commonly inferior to the inferior pole of the thyroid. So this is all for the head and neck and all for today. Thank you for your attention. I will see you in the next section. Thank you.